So another small topic we are going to discuss is the hormones and their role in athletic performance. So one or two questions you can probably expect from this area, and only a few number of points is very important as far as this topic is concerned. So when a person exercises, there is a myriad of hormonal changes that is occurring, and mostly that is on an increasing side. The catecholamines will be increased, the HPA axis will be activated, and both the ACTH and cortisol levels increase, the RAS system activated, the gonadal sex steroids increase, the growth hormone, the adrenal natriuretic peptide, endorphins, prolactin, everything will increase during exercise. Now, before going into the topic proper, I'll just like to discuss about a few points of female athlete triad. So, female athlete triad is in fact a terminology which is coined by the American College of Sports Medicine in 1990, where they have observed the relation between low energy availability. Low energy availability is seen in slim individuals who are eating less, mostly seen with athletes, and the low energy availability was associated with abnormal menstrual function and low bone mass. So female athletes were found to have abnormal menstrual function and low bone mass, and they called this triad as female athlete triad. But as time has passed, we had scientific knowledge that this abnormality of low energy availability is confined not only to women, but men can also affected by this low energy availability. And apart from this low bone mass and menstrual function, so many other parameters can also get affected. So many domains can be affected with this low energy availability. So apart from the abnormal bone function and menstrual abnormalities, changes in the immune function, changes in the cardiovascular function, in the cognitive domains. So everything can be affected as a part of the low energy availability, which we call as relative energy deficiency in sport. And this was proposed by the International Olympic Committee in 2007. Previously, the American College of Sports Medicine was the one which introduced the term female athlete triad back in 1990. Now, a few points with regards to growth hormone and its role in exercise. So, growth hormone level will not increase as soon as the exercise is started. A minimum exercise duration of 10 minutes is required for the growth hormone to start rising, and the maximum growth hormone secretion occurs at 20 to 30 minutes, or books say 25 to 30 minutes. So, only after 20 minutes you will get a sudden spike in growth hormone secretion. And the mediators of growth hormone increase include nitric oxide and lactic acid. So, the local lactic acid and nitric oxide generation in the muscle, they will diffuse into the circulation and they will go to the pituitary to stimulate the growth hormone production. The response of growth hormone following exercise is higher in women than in men, probably due to the higher degree of estrogen increase during exercise. Now, what about the IGF-1 levels in exercise? We have seen that a minimum duration of at least 10 minutes is required for growth hormone to even start rising, whereas significant elevation of IGF-1 has been seen in around 10 minutes of exercise. It shows that there are some factors other than growth hormone which is determining the IGF increase during exercise. Now, coming to performance enhancing drugs, they are also called as ergogenic medications. So, ergogenic drugs, this is the other name for performance enhancing drugs. They are used by athletes and sports persons to increase their performance, their muscular strength and their body composition. So, first use of doping was dated back to 1950s with regards to testosterone. So, testosterone was the first agent which was used illegally for enhancing their athletic performance, and the first formal anti-doping testing which was approved worldwide was during the 1972 Munich Olympics. So, 1972 Munich Olympics was the event from which the anti-doping test was being held, and it was being held regularly from then onwards. About the performance enhancing hormones, they can be androgenic steroids or peptide hormones. So several steroids, several esters of testosterone, then alkyl derivatives, nortestosterone, norandrostenedione, and so many other metabolites of testosterone were used as performance enhancing drugs. And nowadays, as there are more sophisticated tests for easy identification of androgenic steroid abuse, the athletes are shifting more towards a peptide hormone based doping, where they are using the growth hormone, the insulin like growth factor 1, the insulin, erythropoietin, etc. all have been used for the purpose of doping. Now, how does androgenic steroid use helps in building the muscle? It mainly acts by stimulating the satellite cells which are the stem cells or the pluripotent cell present in the muscle cells, and these cells can differentiate either towards myoblast or towards adipoblast, and use of this androgenic steroid will stimulate their differentiation towards myoblast and inhibit their differentiation towards adipoblast, and also they reduce the myocyte apoptosis. So these two are the major mechanisms with which they enhance the muscle mass, and they also alter the body composition in a favorable manner by reducing the visceral adipose tissue. Now, there are certain terminologies in relation to doping. They include, one is stacking. So stacking means use of multiple, that means 2 or more androgenic medications, anabolic steroids, in a progressively increasing dose. That means you combine 2 or 3 androgenic medications, you start taking them at a lower dose and you progressively increase their dose to at a higher level. That is what we call as stacking. Cycling means you are intermittently taking anabolic steroids and then there is a washout time where you are not taking steroids. Then you are again starting to take anabolic steroids, then you are again stopping. So these periods of taking and not taking anabolic steroids is what we call as cycling. That is the intermittent use. So the concept they believe due to which the cycling could be of benefit is that if they are giving a washout period or a period of these anabolic medications, that will help in the desensitization. Otherwise, they believe that this is not a scientifically proven concept. It is a belief or a thought which is widely prevalent over those who are using these doping agents. If you are continuously using these anabolic agents for longer periods of time, they will develop desensitization and they would require very high doses for similar clinical benefit. So in order to avoid that, they would have a period of usage followed by period without usage. That is what we call as cycling. Then what you call as building a pyramid. You know that in cycling, there is a period of usage followed by period without usage. And in the period of usage, they would start at a lower dose and then they will slowly increase the dose of this anabolic medication. Then they would stop it for some time and again they will restart it with progressively increasing dosage. This is what we call as building a pyramid. Okay, so building a pyramid means they are progressively increasing the anabolic steroid usage over a cycle. This is what we call as building a pyramid, and each cycle it amounts to 2 to 3 months. Each cycle would be around 2 to 3 months followed by a washout period. So stacking, cycling and building a pyramid you should keep in mind. Now what are the side effects of anabolic steroids? So anabolic steroids can have cardiovascular, cosmetic, reproductive changes, hepatic changes and psychological and injection related. So cardiovascular include the metabolic abnormalities, the decreased HDL and increased LDL. So decreased HDL, the usual cutoff they say is less than 30 milligram per deciliter, and importantly the triglycerides are normal, with normal triglycerides. Okay. And it increases the cardiovascular risk and reproductive function because these anabolic steroids will go and suppress the endogenous FSH and LH production. The endogenous testosterone production will be absent. Okay, so due to the lack of FSH and LH support on the testis will undergo testicular atrophy and the spermatogenesis will also cease. So there will be testicular atrophy and there will be absence of spermatogenesis. And the recovery of this fertility or recovery of spermatogenesis would take variable amount of time once you stop this androgenic steroid usage. Longer and the larger duration of androgenic steroid usage is there, then less likely is that you will get back the normal reproductive function. So there are reports that those who have continuously used this anabolic steroids for months and years, they had not recovered the sexual function. Sexual function in the sense the fertility and the normal spermatogenesis. And in females, due to the androgenic action, they will develop breast atrophy, hirsutism, then features of virilization, etc. And as far as hepatic side effects are concerned, cholestasis is the most common side effect, and rarely you can have ileosis hepatitis, and also tumors like hepatocellular adenoma and hepatocellular carcinoma even have been reported with the continuous use of anabolic steroids. And it produces a lot of psychological changes as well as injection related changes. And lipid abnormality, we have already learned low HDL, high LDL with normal triglycerides. The HDL level is characteristically less than 30 mg per deciliter. Liver disease also, we have discussed the different types of liver disease that can occur. Now, detection of anabolic steroid doping. So, this has been a previous question in 2 or 3 exams. One is the ratio of testosterone to epitestosterone. So, epitestosterone is nothing but a metabolite in the androgen metabolism, and it is occurring only in naturally occurring or endogenously produced testosterone. So, epitestosterone is found in endogenous testosterone. Epitesto formed from endogenous testosterone, not from exogenous. So, what happens when the patient is receiving exogenous testosterone? The levels of epitestosterone would go down. So, the ratio more than 4:1 is suggested by the International Doping Agency to make a diagnosis of testosterone abuse. Then apart from this epitesto ratio, they have used at other ratios also like androsterone to ethiocolonelone ratio, androstenedione to testosterone ratio. And one more question which have been asked in this regards is regarding the C13 to C12 ratio. So this is done using isotope mass spectrometry. Where they look at the carbon atoms of these anabolic steroids. Anabolic steroid metabolites, they would look at the carbon atoms, whether the carbon is in the C13 form or in the C12 form. So C13 form is more common in endogenous testo, in endogenous androgens, whereas C13 is less in exogenous. So what happens to this C13 to C12 ratio? This ratio will reduce in exogenous use. So these two tests you must keep in mind is the testo-epitesto ratio more than 4:1 and the reduction in the C13 to C12 ratio using isotope mass spectrometry. Now the use of growth hormone in doping, the usual dose that the athletes use is around 20 to 25 units 3 to 4 days per week subcutaneously. And how does it benefit? It increases the muscle mass, reduces the muscle apoptosis. It also alters the body composition, reduces the visceral fat and increases or diverts all these mesenchymal stem cells towards the muscle genesis rather than the adipogenesis. That is the function of recombinant growth hormone in increasing the athletic performance. Now, how are you going to detect the growth hormone doping? You look at a combined analysis of IGF-1 plus pro-collagen 3 N-terminal extension. So, this may remain elevated up to 2 to 3 weeks, after last growth hormone injection. So, elevated IGF-1 coupled with increased pro-collagen 3 N-terminal extension. And also, the second test that we are using is the growth hormone isoform method. You know that in our body, it contains 70% of the growth hormone is in the 22 kilodalton form and 20 kilodalton form constitutes around remaining 20%. Okay. 22 and 20 are the major circulating forms, of which 22 is 3/4 and 20 kilodalton again it contributes around 1/5. But when we are using, this is endogenous GH. When we are using exogenous testo, not exogenous GH, it contains only 22 kilodalton. Only 22 kilodalton is present and there is no 20 kilodalton. 20 kilodalton is not there. So you can look at the ratio of 22 to 20. And the ratio, if it is very much increased, then you can say that the patient is taking exogenous. So when you are taking exogenous GH, it will increase the IGF-1 level and this IGF-1 will go and inhibit the pituitary GH production. So both the endogenous 22 and endogenous 20 kilodalton form production is suppressed and only the exogenous 22 kilodalton will be circulating. But the problem is that this test should be done within 24 to 48 hours after last injection. So even though this is a very sensitive method, unless you are getting the sample as early as 2 days after the last injection, you are liable to miss the growth hormone doping that has been performed. Now, like growth hormone, you have other peptide hormones like the IGF-1 injection, the mecasermin injection, erythropoietin analogs have also been used to increase the athletic performance like the darbepoetin alpha. So then peginacetide, again it is a pegylated molecule with 2 erythropoietin moieties. 2 erythropoietin moieties are linked together by pegylation, that is peginacetide, and you have sotatercept. Sotatercept is not exactly a erythropoietin analog, but it is an erythropoiesis stimulator. So this also has been used in doping over the years, and the method with which you differentiate between the endogenous and exogenous erythropoietin is by looking at the glycosylation differences. You look at glycosylation differences between the two to distinguish between the endogenous and exogenous erythropoietin. So these are some of the salient points with regards to hormones and athletic performance. The important points that you have to keep in mind is about the anabolic steroids, their side effects, how are they detected in the doping, the urine test, the ratios and all you should keep in mind. What is the role of growth hormone in doping? How are you identifying the recombinant growth hormone in doping? And also the points with respect to the growth hormone changes during exercise, the time points like the 10 minutes, 20 minutes, 30 minutes, all that time points also you should keep in your mind.